Good afternoon and good morning to all of us. My name is Tapson Nyondo. I'll be your moderator today. Happy New Year. This is the first LabCoP Eco session that we're having today. So let me welcome you to the 2025 first LabCoP Eco session. Our topic today is utilization of resource utilization and improvement of program outcomes through innovative dashboards. As you're aware, monitoring and evaluation is a critical component in terms of the lab systems and networks. And today, we'd like to learn more about how can we use the M&E functions that includes learning, adapting, to ensure that we align and achieve the intended outcomes of the project. And the focus of today is to focus more on what else can we do and how can we take advantage of the technologies like dashboard, the innovations like dashboard, to increase the access of data to users and decision makers so that they're able to make a decision and make corrective action and improve their results or their outcomes that they designed at the origin of the project. And because of that, we'll hear from the Ministry of Health Tanzania, where they're going to show us and demonstrate to us the kind of dashboard that they have, integrated dashboards, and how they're able to bring people together, especially the different technical working groups that sits together to review the dashboards based on the indicators that they have in the dashboards, and also identify the root causes analysis, and design strategies that should be able to improve their program, HIV program. We know that LabCoP has been supporting about over 22 countries in Africa, and Tanzania has been part of this agenda and this journey. Today, I introduce to you Jacob Sekero from the Ministry of Health, Tanzania. He's a National Quality Laboratory Officer and has over about 13 years of experience. He's one of the users, but also a decision maker of the dashboard, but also the journey in Tanzania to improve the use of data, but also to ensure that the programs achieve the intended results that include the 95. So I introduce to you Jacob, who is going to present to us. After the presentation, we're going to have questions from the audience. You are free to put in the chat box, but also you can ask, but the chat box will be the best. Then after that, there will be responses from the team Tanzania. Maybe some of us will also be able to respond. At the end, we'll also ask you to suggest some of the topics. This is the first series in M&E under LabCoP, but we intend to have at least 6 sessions this year. And we hope by also suggesting to us, we should be able to be relevant, but also address the needs across Africa and also ensure South-to-South learning in the M&E. So I invite Jacob from Tanzania to take the seat and make a presentation. Over to you, Jacob.
Thank you so much, Tapson. As Tapson already introduced myself, I'm Jacob Lusekelo. For those who have met with me in different projects, this is me. I've switched on the camera just for everyone to have a glimpse and to know who is presenting. National Laboratory Quality Officer for the laboratory services from the Ministry of Health, Tanzania. And we are delighted to be the first one to present on the M&E SubCoP for the 2025. Among the 6 planned sessions, the Tanzania will be the first one. So thank you so much, ASLM, for having faith on us. We have presentations and some slides to share with you today, which will showcase the use of dashboards here in Tanzania and the data that we have gathered from different dashboards, integrated them and put them into actions. So this will be the overview of our presentation today. We are going to see the organizational structure within the Ministry of Health, and then we are going to see the assessments that the country has been participating, in particular, the laboratory services. We are going to see the different dashboards, and I know that there will be some new terms today, like ESCRIS. I'm going to define them shortly, and CTC macro dashboards. And we are going to pass through the system integration and transforming data into actions, and the challenges which we have seen, and some risks, but also we are going to share with you some lesson learned through our journey. So today, when we'll be speaking about CTC, is care and treatment clinic, but for our presentation and for our database, the CTC is the name of the database that has been placed in all CTC clinics just to monitor the PLHIV patients or clients that are attending the clinics. So yes, we know that CTC, the name of the centers, but as well, our database for monitoring the client's records is also called CTC. So we have CTC2, which is a database which capturing the information, and we have CTC3, which is the central database at national level, which is helping us to visualize the data from the clinics. So the CTC2 is at the clinic level, that's where they are inputting data, and CT3 macro is the one that is available at the national level. So we will also hear about the term DDR, and I'll be presenting them as I go along. This will be the diagnostic data repository, and DNO is not very new to you, diagnostic network optimization, and all other terminologies. Today I will try to elaborate them as I go along with the presentation. So as you are aware, and some of you have been into Tanzania, we are located at the eastern region of the African continent. We are bordering with Kenya, Uganda, Congo, Zambia, Malawi, Rwanda, Burundi, and Indian Ocean at the eastern side. And we have the population of more than 67 million, and we are, like other countries, striving to achieve the global target of ending HIV epidemics by 2030. But currently, we have this prevalence at general population of 4.4%. And all this data that if you wish to visualize, you can just go and search for Tanzania HIV Impact Survey for 2023. Then you'll get all the information that I'm presenting in the data. So the organizational structure, I know one of the pillars of the ASLM and Africa CDC is striving to ensure that all the member states, they have the laboratory department within the Ministry of Health. We have tried and we have strived better, and we are lucky that we have managed to secure the unit within the Ministry of Health, and currently this unit is overseeing laboratory services along with imaging and re-imaging services and healthcare technical services. So the laboratory services are headed by the head of laboratory services. And today we're going to abbreviate as HLS. So the head of laboratory services within the Ministry of Health oversees several other subsections which report to him. And within these subsections, there are technical working groups which involve different stakeholders, partners, who they are collaborating together to solve some challenges regarding laboratory services. So we have surveillance subsection, which oversees the monitoring of diseases that are linked with surveillance unit at the Ministry of Health. We have vertical programs unit, which oversees all the vertical programs that are supporting laboratory services, but also this unit also oversees the sample referral systems. We have dedicated the supply chain management subsection. We have the quality management subsection, biosafety and biosecurity. HIV and viral load, they have their own subsection. And we have specific subsection for M&E, which compiles all the data that are coming from different TWGs and report them to the head of laboratory services. And we have the research and the training subsection and the ICT subsection. So today we are going to dwell much on the ICT and M&E subsection, because we are discussing about the use of dashboard to improve laboratory services. However, we have the programs that are supporting program diseases such as National HIV program. We have National TB and leprosy program and National Malaria Control program. All of these collaborating with the laboratory services section just to ensure that the data that are collected within these programs also reach to the laboratory unit at the Ministry of Health. So the structure of reports and information in the country is like this pyramid. We are starting from national level, and we have zonal level, we have regional level, district level, health center, dispensary, and sample collection unit. So whenever I speak about laboratory network within the country, you'll be referring to this diagram that sometimes we get samples from sample collection units or dispensary or health centers, and sometimes they go all the way to national. However, we have decentralized the services at each level, like the viral load conventional services is available up to the regional level, and the point of care services is available to other primary health care facilities. So now I'm just going to highlight to you some of the assessments that Tanzania has been participating and the improvement over the years. So as has been highlighted by Tapson, Tanzania is among the founder countries of the LabCoP since 2019. We are glad that we were part of LabCoP since the inception. And then we have been participating in various assessments and various tools such as WHO scorecards and ASLM scorecards for improvement. And I know that you are aware of the other tool of LabNet. So all of these tools have been used for assessments. And Tanzania has consistently been utilizing these assessment results to improve laboratory services. So if you can see and visualize the domains for HVL improvement, you will witness that we have consistent improvement on the demand creation, sample collection, sample transportation, result utilization, leadership and management. However, the supply chain and equipment maintenance still has slow pace in improvement due to we have faced the change of CAP-CTM equipment to to newer platforms. So we experience stockouts and or other things because of the change of the equipment and technology. The HVL testing, this is due to the change of indicator. I know for those who are conversant with our scorecards, there is a change of indicator, and this indicator includes the integration of other diseases as well. So we are among the countries that we are struggling to have integration of services within the platforms that are doing HVL testing. So that's why we have slow pace in HVL testing. But you can see that we have good progress in waste management and biosafety. This was just for HVL, but if you see the data availability at the national level, you will see like from 2023 to 2024, we have managed to reach all indicators that have been put by ASLM LabCoP, and we have managed to have all data at national level, even for the troublesome indicators such as clients who were suppressed sometime. The data was somewhat not available at national level in 2023, and those one who switched to second to third regime, sometime it was not available at national level. So what happened to 2022? The data was not submitted to SLM, so that's a different story. But looking at the improvement that we are proud of is having all this data at national level. And we were facing the clinical laboratory interface, like we have the good data at the clinics, at the CTC, but that information we were lacking at national level, especially at the laboratory department. So today we are going to show you what made us reach this goal of reaching 100% indicators of LabCoP, of having all data at national level. So as I highlighted before, we have the CTC2 analytics, and this CTC2 analytics is a web-based database positioned at the clinics, and it captures records of clients, their visits, their change of regime, and their suppression level. So this database has been linked to the diagnostic data repository at the Ministry of Health, and we are able to visualize data at national level through CTC Macro 3. So CTC Macro 3 is the name now for the dashboard, which is used to visualize CTC2 data. So I just want you to know that we have managed to put this database at the clinic level, which is linked to the laboratory, and we can visualize that at national level. This is the area that I want to highlight to you, the joint external evaluation results. I think most of us are participating in the joint external evaluation, which is organized by WHO and other stakeholders. And we participated in JEE 2016 and August 2023. You can witness significant improvement in sample referral system, in the laboratory testing capacity modalities, and effective national diagnostic network. If you really know the JEE tool, the indicators are somewhat changed the names, except the quality management system and the national referral and transport system. So initially, indicator D11 was known as laboratory testing for detection of priority diseases, and now has been upgraded to be effective national diagnostic network. This one we have managed to move from 3 to 4, which indicates that we have demonstrated capacity within the country for effective national diagnostic network. And this network oversees even the laboratory information systems, the integration of the laboratory information systems and information sharing between the laboratory tiers within the laboratory network. So we are proud that we have managed to reach to level 4, which is demonstrated capacity, but we really need to reach to 5, which is sustainable capacity. So in order to reach the sustainable capacity, we really need to test, to exercise our system if it's capable of running without external support, you know, when I'm saying the sustainable capacity. Sample referral and transport network, we scored 2. That was limited capacity in 2016, but we managed to reach 4, the demonstrated capacity. And we are going to share on how the laboratory information systems and database helped us to move from score 2 to score 4. And we have, initially, we had this indicator called effective modern point of care and laboratory-based diagnostics. But in the recent edition of JEE has been updated to laboratory testing modalities. And this indicator, we scored 3. And in 2023, the recent evaluation, we scored 4, which is demonstrated capacity. The laboratory quality system, we scored 3, same as 2016. But if you read the report, it indicates that the human health quality management system is 4, and for animal health is 3. So you know that JEE, we use the lowest score. So we need to pull up the animal health with the national standards and establish their quality management system to be the same as level 4. But for human health, we managed to move to level 4. So today, if I was presenting only for human health, I would put score 4. But since we are presenting as Tanzania and One Health approach, we have to take the lowest score. The laboratory information system contributed to the significant improvement of the indicators. As you can see, most of the indicators here are somewhat supported by the laboratory information system. So I want to share with you this database of HFR portal, which is Health Facilities Registry in Tanzania. And when we share this PowerPoint presentation, you will be able to access them through this link, and it's easily, and you can just navigate within our health facilities in Tanzania. And this system helps to visualize number of health facilities, including the laboratories that we have in the country. And the system has enabled us to utilize the data, especially the GPS codes that are available in the database, to have an effective DNO that we have conducted. And if you visualize the system, it will indicate the number of health facilities that has been registered, which one are private, which one are public, and the number of laboratories actually with their relevant level. And I want to share now with you with our famous electronic sample referral system, which is a system and is a web-based system used to track samples from the point of collection to the hub and then to the testing lab. And the system has integrated the HIV, TB, HPV, and surveillance samples. And the good thing is we have integrated the ESRIS system with the courier tracking system. So the laboratory can even be able to visualize the location where the sample is. And we have scaled up to include the tracking of influenza samples and imaging and re-imaging. So within the national level, we can be able to visualize the samples that has been received per each region, samples that have been rejected per lab, and where the samples are pending. Maybe the laboratory has collected the samples, they've put in the system, but they've not yet shipped. So we can even visualize the number of samples that are pending in which facility. So this is the one area of the ESRS that can do. And the ESRS, which is electronic sample referral system as well, can even track the agreed laboratory indicators, such as number of samples tested with results. And as well, this one can give you even the turnaround time from when the sample was shipped to the laboratory and when the results were logged back to the clients. And this also indicates the number of rejections that we have within the country and their proportion and the reason of rejection. So even at national level, we can pull this data easily and at real time. And this one, we want to highlight to you that the dashboard, the ESRS dashboard, can even track the number of samples that has been received to a particular area because we are tracking them. But also we can even see the trend of samples that have been received in a particular region and the samples that have been shipped out per month and per year. So we can even see the samples that have been received, the sample that have been tested, and the number of samples that have been rejected. And this database also analyze all these indicators and pull up the report, which we now discuss to the technical working groups, which I will share you in just a few minutes. So after showcasing the capability of the electronic sample referral systems, let me talk a little bit about the CTC analytics, which I highlighted earlier on. We have published this book of CTC analytics. You can even Google the name and you can find through LabCoP dashboard, LabCoP website. So this CTC analytics, which is the web-based system which is available in the CTC clinics, helps to view the performance data of the particular site. So the particular site can even visualize the number of clients that are available at the facility, the number of lost to follow-up, the number of those who have changed regime, and the suppression level and their number in percentage. So these records that are tracked for confidentiality purposes, the system generates unique code which communicate with the laboratory information systems, and that code is used to upload the result. So what we are seeing at national level, we can be able to visualize the number, but at laboratory level, they can be able to visualize the unique code that has been developed by the system. And the dashboard has interface to visualize all these indicators with their numbers and percentage. And we have two types of data that is being used to this CTC analytics. We have data that is being uploaded at the facility level, and we have that data that has been analyzed by the system. And nowadays, we have the data, especially the laboratory results, that come automatically from the laboratory to the system. So you can see that we have a wide range of laboratory information systems, including the disease-specific systems, the analytical systems, and so forth. But we want to share with you that all these systems you see here, they've been integrated well, and we can even visualize data at central level. So at spokes within the facility, what we have is the CTC2 database, which I have spoke very much today. And then we have ESRS database, which tracks the samples that have been collected at CTC. And then this ESRS is one that's sending back the result to CTC. So ESRS acts as a tracking web-based, but also is a fully fledged laboratory information system now to the conventional laboratories. So ESRS acts as the tracking, but also the laboratory information systems. And within the central now, we have the CTC3 repository, which we can see all the client records. We have the central database from the laboratory information system, and we have DDR, which is a repository of all the laboratory information systems and other dashboards. So the DDR we are sharing with you today has interlinked all the laboratory information systems within the country, but also has connected with all the hospital information systems through the health information mediator. So mediator is acting like the bridge between the clinical and lab interface. And we have dashboards that we can visualize at national level, such as EMR and CTC macro from CTC, and we have ESRS dashboards, and we have all those dashboards from laboratory information systems. All these are linked to the open data repository, and we are working to have the comprehensive dashboard that will show all the data that has been stored in the DDR. So how are we using this data? All the data from the dashboard collected, analyzed, and each coordinator within the specific subunit is the secretariat member of the technical working group, and each technical working group has established the terms of references indicating the frequency of the meetings and the participants for that meetings. So we have the sample referral system technical working group, we have HIV viral load technical working group, laboratory information system, quality assurance, supply chain, laboratory-based surveillance. All these technical groups, they have their specific terms of references, and they are responsible to interpret the data, to do the root cause analysis whenever there is a problem, and to come up with a solution and advice to the director of the diagnostic unit, who in turn give the advice to the upper management. So sometimes we can see like we have huge number of rejections, and we come up with the root cause, and that root cause we advise properly, and sometimes we have to change even the policies, such as the HAID. We had a lot of rejections previously, so we had to change some policies, procedures, and manuals to include the training program of healthcare professionals on how properly they can collect the DBS samples for HIV early infancy diagnosis. So today we are going to share with you how the data, apart from the assessment improvement, has improved the laboratory services in the country. So improvement of sample referral system, we have witnessed that we have reduced the TAT of sample transportation from 7 days in 2018 to 24 hours in 2024. So the same facility which was used to send sample from the clinic to the testing laboratory for 7 days, now they can be able to send samples within 24 hours. We have real-time reporting of equipment functionality and breakdown, and this is another area that we want to highlight to you, that we have the information system which shows the breakdown, and the information is communicated to the manufacturer whenever there is a breakdown. And we have the real-time reagent consumable requisition reporting. Initially, we used to do the manual work, but nowadays we are using the system to do all the reagents, consumable, and the requisition. And this one has improved even the procurement system of laboratory services, especially we used to count the reorder level, but now the system helps us to count the reorder level and prompt us when the times to order. We have the real-time reporting of error rates and identify the trends for improved laboratory efficiencies, as I highlighted for the DBS, for example. This is just to highlight to you that how the dashboard can alert us and can give us the trend. And this is like the example of the TAT for HFL results. You can see that we have improved over time from 2020 to 2024. The TAT has improved so much from 11 days. Nowadays, we are playing with 3 days. So all these dashboards that can help us to identify trends. And then we have utilized the dashboard to have the DNO instead of doing the site-specific DNO. This time we used the database, the data from the databases to know the location and to do the desk review and to complete the DNO report within short time. And we have enhanced communication between the facilities, especially we have the CTC database, the HFL and HAID dashboards, which shows the performance of the site. They can even compare themselves to other facilities and they pull up the SOCs from the dashboards. We have early detection and confirmation of disease outbreaks, such as malaria, COVID, Marburg, and cholera, just to say, because we have real-time information sharing between the facilities to the national level. We have identified some challenges. We have inadequate integration of laboratory and disease surveillance data. What we are working with now, we are working on integration of all health systems. And the good thing, we have established the Hospital Information Mediator, HIM, the one that I showed with you. The HIM supports the integration of each kind laboratory information systems available in the country. And the good thing is we have the Diagnostic Data Repository, the DDR, which acts as the basket of all laboratory information system data. And we have noted that we have inadequate expertise in laboratory management among laboratory professionals. So what we are striving is we have in-country capacity building program for field epidemiology at MUHAS, but also we are planning to conduct the global leadership program at MUHAS as well to increase the number of people and professionals with adequate expertise in data management. We have inadequate data management, inadequate monitoring for disease which are not supported by programs such as bacteriology, diseases, hematology, and so forth. So we are increasing the existing EMR with supported donor systems. We are doing advocacy, but also we are using the resources that has been allocated and the same system for other diseases as well. So now I'm going to finish through the lesson learned that the system integration is essential in data management. Initially, we used to have various systems which are not integrated, and having a comprehensive dashboard was very difficult. And joint planning, we have joint planning through this through this TWG is essential in framing laboratory indicators, because you can have a lot of lab indicators and sometimes becomes cumbersome. So, but if you have joint planning, you can have same indicators which are monitored across the country. And the clinical lab interface, such as CTC, is a critical to ensure comprehensive data management for decision making. So thank you so much and welcome to Tanzania. We have various areas to visit. Karibuni sana.
Thank you, Jacob, for a wonderful presentation. As you can see, as we move towards integration of this device, network optimization, and we have also heard from Jacob that even data itself needs to be integrated for it to be available, but also easier to use by the decision makers and implementers to improve their services. Jacob, we have questions from different people. And I think one of the questions is your system tracking samples individually or aggregated? And what kind of system are you using for that? Do you want to take all of them first, or we review for one and you move to another one?
You can do one by one because I have to write. Yeah. So we are using the electronic sample referral system, and our system is capable of tracking each sample that has been entered in the system. However, the courier system that we have integrated with, it tracks the package of the samples within the package. So what the system does, we have integrated our system, which tracks each and every sample that has been shipped within a pack, of which the pack is being tracked by the courier system. So if we can be able to locate the pack where it is, it means all the batch of sample that has been shipped, they are within that package. So what ESRS does, it gives the information of each sample that is within the pack, which is within the courier tracking system. So that's how we do tracking, and we can track individually, but also within the package.
Thank you, Jacob. Another question is equipment reporting. Is it automated from RIS, RIMS, or is a separate system? But also on the same, you have already tackled the first one, but there's also integration of private clinics. Is it part of the system or is different?
The equipment monitoring, this is different system. This is the laboratory module that has been that is within the supply chain module. So this laboratory module is currently we are reporting, the user is reporting the equipment malfunctioning, and the information is sent direct to the national level and to the manufacturer whenever there is malfunctioning. So the same system that we use to order the supplies, there is a laboratory module which is reporting the equipment functionality. And this is different from the one that we are tracking sample, because the one that we are tracking sample is the, as I said before, is the tracking, but also the laboratory information system. But what we are heading probably in June or December with our consultant, we will be able to pull out all the laboratory, the information systems within one dashboard, a comprehensive one. Even the equipment monitoring system will be covered within the comprehensive dashboard. Over to you, Tapson.
Thank you, Jacob. The same question has come up in terms of the private sector. Is it part of your ASRIs? Or maybe you can just share the central dashboard.
Excellent. Excellent. So currently, we have 320 hubs within the country. And these hubs are not only the public sector, but also we have the private sectors as hubs. So ESRS tracks all the hubs information systems. So even the private sectors, whenever they have a hub, we can track the samples that have been shipped. However, the information systems within the private sectors are not yet linked with our comprehensive dashboard. But the private sectors which are testing the HVL, we have integrated their systems as well, because they are using the same ESRS as laboratory information system, but also the ESRS as a tracking tool.
Thank you, Jacob. As you can see, Jacob is a program officer, and the data use requires, sometimes we think that data use is about people that are in the data themselves, but you can see Jacob is a program officer who is able to articulate and is proved that he's able to use the data to advance and improve program performance. At this point, another question is the pack for the samples barcoded for you to be able to track the pack?
Excellent. So that's the requirement, and it's a prerequisite from the couriers that we have contract with. So whenever poster, we are using poster in Tanzania, which is called Tanzania Postal Corporation. Whenever poster transport samples, they put special barcode for them to be able to track. So what our system does has been linked to that barcode and gives us information of where the package is and the whole samples within the package. Yeah.
Thank you, Jacob. Maybe just to find out, you presented a beautiful structure. What's the role of the director in all this, and also the other directors in the ministry that have an impact on your system? What role do they play to ensure that there's continuous demand, but also follow up on the actions that you have identified through the gap analysis that you undertake via the dashboards? Thank you.
Thank you so much, Tapson. So the Director of Diagnostic Services, along with other directors within the Ministry of Health, they have primary responsibility of ensuring that the policies and the strategic plans that have been developed are implemented accordingly. So within the laboratory information system, we are implementing the health sector strategic plan, version 5. We are implementing the National Laboratory Services Strategic Plan. Currently, we are using the operational plan strategy from the strategic plan. So all these plans have indicators which needs to be reported according to the established timelines within the established plans. So what we do in our sections, we are making sure that all the data that has been stipulated are reported back. So for instance, most of the famous indicators that our leaders wishes to see, the equipment functionality, the improvement on customer satisfaction, and availability of reagents and commodities. So all these big indicators have various small indicators according to the technical working group. So all these indicators are tracked, and we are reporting back to the Director of Laboratory Services. And also the Director of the Diagnostic Services, he's the chair of the National Laboratory Advisory Committee, which oversees all other technical working groups. So that's the role the director is playing, along with other directors in their respective departments.
Thank you, Jacob. Leading from the front and the leadership, I think, is critical factor to make sure that data utilization is continuous in the system. We have other questions. They have talked about the challenges with stockouts during transition. Also noted that you have a way for monitoring equipment too. Can you speak a bit more to how you leverage this data to engage with the manufacturers or suppliers?
Thank you so much. This one, maybe my colleagues from Viral Load and HAID are available here today. They will help me to respond. However, the transition we foreseen beforehand, the manufacturer communicated to us beforehand, and we developed the transition plan. And the transitional plan was authorized by the Ministry of Health. And then due to the planning and calculating the stocks that we will have, we stopped ordering the consumables for the platforms that will be phased out. So currently we are using other platforms that were here while waiting for those big capacity to be moved out. And then we will come up, we will bring the new platform. So within this transition period, we had the transition plans, and these transition plans, we developed them along with the manufacturers. And we usually have extraordinary meetings when it comes to issues relating to manufacturers and issues relating to verification, validation, and changing of methods such as capacity. So within those extraordinary meetings, we have the manufacturers, we plan together, and we developed actionable items to make sure that we don't have interrupted services. Over to you, Tapson.
Thank you. There was a question that I think there was a course that advanced epidemiology course at MAS has been there for 5 years. How does it become a challenge to make laboratory data? That relates to one of the slides on the challenges and way forward. So
Yes.
there is some feedback that is being asked here.
Yeah. Thank you so much, Tapson. As you recall during my presentation, I didn't say lack or no expertise. We said inadequate expertise of laboratory professionals in data management. And we acknowledge, that's why I say that we have in-country capacity for Tanzania field epidemiology. But the number of laboratory professionals that are graduating each year is not more than 7. And this does not cover all over and all angles of Tanzania. That's why we are saying we have inadequate professionals to support with the data management at all levels. And mostly, whenever we know that whenever someone has advanced education, master's program, we tend to move them from the clinical level, from lower facilities, to bring them to the national level. However, we forget that we really need to have that expertise at primary healthcare. So we are striving to establish courses, advanced courses, such as global leadership programs and other intermediate and advanced level training programs to ensure that we have adequate professionals with capacity of data management, analysis, reporting, and even publishing research data from the courses that will be offered. So that's a challenge. We really acknowledge that we have inadequate number and we need to do more to ensure that we have adequate professionals.
Thank you, Jacob. If you need some help with your friends on any questions, you can always mention so that we can switch them in to answer the question. You have a lot of questions today. That tells you the interest in this topic. So we will keep on coming, and we know that you have a capable team that you're working together. So the other question is, you have talked about changing policy. What are the challenges that you encountered during the rollout process, and how did you mitigate them? If you have other colleagues that should take care of the question, you can mention them. They should be able to be given rights to talk.
Yeah, I know that my colleagues are busy responding to the questions on the chat.
Yes,
I can see.
they are. I can see them.
I hope that they are going to respond to other other challenges, other questions as well. Yes, there are a number of occasions that has led us to the change of policies and mitigation of the policies. I can't give really example, but we have witnessed the number of situations where probably a certain device is not performing well, and we have put that in our national policies or national algorithm. And in such instances, we switch the policy and to the another algorithm, or change the device, or change the method or testing methodology as well. Also, we have encountered some situations of advancement of technologies, and when we were introducing the Genie Expert, we introduced the Genie Expert for TB testing, but the advancement of technology, we noted that Genie Expert can also do other tests as well, such as viral load and HAID. We had to review our policies to integrate the testing systems and the algorithm as well, to ensure that the point of care is well taken care to other diseases as well. So those are such instances that has led to even change to the policies and mitigation measures.
Thank you, Jacob. Another question, there's so many. Can you track rejected specimens that are collected and received for testing? What percentage of rejected specimens are received back for testing?
Can you repeat the question? And if it's well heard.
Can you track rejected specimens that are collected and received for testing? And what percentage of rejected specimens are received back from testing? So even your colleagues can also respond in the chat in the interest of.
Even they can even speak. Bureta, Saidi, Peter, Rodriguez, make sure that we have responded well to the question that in some instances, do we have retesting? Which is yes, we have retesting, and our system prompt us if it's a retesting, and to what percentage results are turning back. Now, that one is a tricky, because we have to go back to the database to see. However, my colleagues can maybe give the average figure of what percentage of maybe HIV results are returning back. I know they are referring to HIV. At my level, I'm overseeing all diseases. So to know exactly the percentage in number is somewhat difficult. So they can respond that to the chat.
So while they're responding, there's another question that talks about the integration of the same data of the Public Health Institute, especially during the outbreak. I know you mentioned the number of diseases, but we also know that the Public Health Institute plays a great role in terms of surveillance and also other things. Is the system able to, or do you plan to integrate with the Public Health Institute on the priority diseases, apart from the one that you showed?
Thank you so much.
In the interest of time, you can also talk to this. Do you have partners supporting the implementation of these data management tools? Or if yes, how are they coordinated to ensure harmony of purpose, considering their specific interests?
Thank you so much. I will start with the National Public Health Institute, Tanzania. We are in the process of establishing the National Public Health Institute, but currently how we are operating, we have the National Public Health Laboratory, which communicates direct to the ministry, where we have the Epidemiology and Surveillance Unit. So if you combine the offices of the Ministry of Health and National Public Health, that makes an institute. So what we do, we have the IDCR system, which tracks all the cases. but also we have established the EHMIS, Electronic Hospital Information System, and we have the National Laboratory Information System, National LIS, which also capture the laboratory information system. The tricky part is how the data for public health, such as surveillance data, is linked with the IDCR database. So we have got the solution for that. The DHIS2 will link with the National Laboratory System. So I think by June, we'll be speaking about the integrated laboratory data with EIDCR system. How we coordinate the partners. Thank you so much for raising this, because I really wish to acknowledge all the partners that they are supporting us, and I can see the number of them that have attended here, from the development partners up to the implementing partners. We really acknowledge their support. We have a number of partners in the country, but what we are bringing them together and what we are doing, we have the centralized technical working group. We plan together, and this presentation has been made possible because of the inputs from these stakeholders. So we shared with the partners, and we jointly agreed with all the information that we have presented. So we have joint planning meetings within our technical working group meetings. We have actionable items, and we are reporting back the implementation of the actionable items. In terms of the organization, Tapson and other people, I think.
So Jacob, we are running short of time. I would like to thank you and for a wonderful presentation. Apologies. And also would like to thank the participants that have asked very good questions. Have a closing marks, then we can close. Remember to submit topics for next M&E sessions. Thank you. So we can have closing marks, then we can close quickly. Thank you. Hello, Jacob.
Oh, I thought the closing remarks are coming from ASLM. Thank you so much.
Just close, yes.
Thank you so much. I wish I could invite one of our partner, but I don't know where the location, because I will just ambush them. We really appreciate ASLM for giving us opportunity to be the first country to present on AM&E for 2025. We are committed, and we are here to provide any assistance to any member states who wishes to learn more. Thank you so much, Tapson.
On behalf of SLM and also LabCoP, I would like to thank you all for joining and also being very active. Thank you very much, and we share the recordings and all the notes. Thank you. Have a nice day. Thank you.